Hi, my name is Kameron Noyama, and I'm a senior honors student at the University of Hawaii at Manoa School of Nursing and Dental Hygiene. I'll be getting my Bachelor's of Science in Nursing. So I'm here today to talk a little bit about my research and my experience doing research as an undergraduate. It's a relatively new thing, but it's very exciting for an undergraduate to be able to do research. So I'm going to start with my research and what it was. So my research was distress levels in newly diagnosed, ethnically diverse breast cancer patients in Hawaii. So you may be thinking, what is distress? So distress is a multifactorial, unpleasant emotional experience of a psychological, social, and or spiritual nature that interferes with the cancer patient's ability to cope with cancer, its physical symptoms, and its treatment. Distress continues along, distress extends along a continuum from normal emotions such as feeling vulnerable and some fears to disabling emotions. And the disabling emotions are things like social isolation, anxiety, depression, all things that are going to interfere with a person's ability to cope. So now, how do we measure distress? So the National Comprehensive Cancer Network developed a tool called the distress thermometer. And what the distress thermometer is a 0 to 10 self-ranking scale. And then attached to it is a 38-item problem list. And on the problem list, it has 5 main categories, which are practical problems, family problems, um, spiritual and or religious problems, emotional problems, and physical problems. And according to the National Comprehensive Cancer Network, where a referral needs to be made on that 0 to 10 self-ranking scale is a score of 4 or more. And this is where they found that distress becomes overwhelming and they can't cope. And this is when, as a medical professional, we need to intervene, and we need to intervene appropriately. So the purpose of this project, or this research, was to identify demographic, disease, and hospital process variables associated with high distress levels. And for this, we had 4 research questions that we wanted to ask and answer. The first one being, what is the level of psychosocial distress that a patient is experiencing? The second one is, are there demographic variables associated with high distress levels? So what we're looking at for these demographic variables were things like age, ethnicity, employment, insurance status, and marital status. And then we also looked at, are there disease process variables associated with high distress levels? So what we wanted to look at with this was, does their stage and grade affect their distress? Or does the type of treatment they're going to undergo affect their distress? Or does the number of comorbidities they have affect their distress? And then the fourth question that we wanted to ask was, are there hospital process variables associated with high distress levels? So we wanted to look at, are referral delays affecting their distress? So if a patient can't come in and they have to reschedule for 2 weeks later, does that affect their distress? Or does the number of providers they see affect their distress? So if they see 5 doctors on one day and they know they're going to have to go through all 5 appointments, does that affect their distress? Or if they know that they're going to see multiple nurses, does that affect their distress? So now that we know the research purpose and the research questions we wanted to ask, we're going to focus on the methods and how we did it. So what this study was a retrospective chart review from March 1st, 2012 to February 28th, 2013. And it was an exploratory descriptive study. And it was the first of its kind in Hawaii on distress and the use of the distress thermometer in breast cancer patients. So what we did was we collected data from patients' medical records retrospectively. So we would look for the distress thermometer, which was filled out by the patient waiting for their initial consultation. And then we looked through for the demographic variables. So we took things from their face sheet, and then we looked for disease process variables. So we looked for notes that had things like their type of treatment, their stage, their grade. And then for the hospital process variables, we reviewed if there was notes saying that they had a refer delay or they had a treatment delay, and we wanted to identify all those things through the notes. And all this was done um, with de-identified patient data because we wanted to protect our patients. And we were IRB approved by the Queen's IRB and also the Western IRB. So once we had our patient data, we took it and we de-identified it and we placed it into SPSS. And then we analyzed it using descriptive and inferential statistics. Sorry about that. Had a slip of the mind for a second. So now that we went through everything, we went through the research purpose, the questions, and the methods. How did we? What kind of results did we get? So for research question 1, we found that the mean distress score for these patients was 2.97 with a standard deviation of 2.98. But we found that 1/3 of our patients experienced distress greater than or equal to 4. Now, if you remember, 4 is the cutoff score for when a referral needs to be made. So that was significant for us. And then for the demographic variables, or are there demographic variables, research question 2, we found that insurance status was associated with high distress levels. So if a person didn't have insurance, or if they may not have had insurance that covered them and that caused them to have to switch insurances, they had a distress level greater than or equal to 4. So what we didn't find was that age, ethnicity, or employment status played a role in this. But it's hard to say about employment status because a majority of our participants were full-time employees or were retired. And in the general population of cancer, you may not see this. And especially because majority of our participants were older. The mean age for this study was 50.7 years old. And as you know, cancer affects people of all ages. So for research question 3, are there disease process variables associated with high distress levels? So what we originally thought was that a person with a higher stage and grade would have a higher distress level. But we actually found that there was no association between stage and grade and type of treatment for distress, which was really interesting because typically when someone thinks of cancer, they think maybe the worst type of cancer that they have would affect how they view distress. So I'm not sure what caused that. And then for the 4th research question, are there hospital process variables associated with high distress levels? We found that people who experienced referral delays were at risk for higher distress. So if a person had to reschedule or if they had a delay because their insurance wasn't going to cover something or they were pending insurance approval, then they had a referral delay, and this caused them to have an increased distress level. And once again, it was greater than or equal to 4. And that's that big cutoff where people need to be referred. So now that we know which research questions we answered and if it was supportive or not, there was additional findings that patients experienced that weren't statistically significant, but they were significant for a medical professional, meaning if we saw this and they presented with these symptoms or these issues, we would need to address it. And some of the things that we saw were people who had skin that was dry and itchy, or difficulty bathing and difficulty getting around. So those were some things that, as a medical professional, we would have to address. So now, the last part of the results that we had were actually very interesting. They were both statistically significant, and they were something that would need referral. So what we found was that on the distress thermometer, if you remember, the 38-item problem list has a section labeled emotional problems, and they were things like depression, anxiety, nervousness, worry, sadness, and then a loss of interest in usual activities. And all of these were associated with higher distress levels, meaning that if they marked yes for any of those 6 things, the depression, the nervousness, anxiety, sadness, all those things, they were associated with a higher distress level, meaning it was greater than or equal to 4. And at this point, we would need to intervene for these patients. So that was extremely important for this study because we found it as if these women marked these issues, we would be able to address them and we would have the resources to address them. So that was my study and the results of my study. So there were some limitations to my study, and it was the small sample size, and then it was the fact that the participants wasn't representative of the population because of their full-time employment status being all women, and majority of them were insured also. So for the future studies, we would want to do a larger study that included males, and we'd also wanted to do a larger study that included different cancer sites. So we want to see if different cancer sites have different distress experiences. So now that we know my research, what was my experience like doing research? So my experience doing research was very real, I guess you could say. There was at one point where I had submitted my IRB to the Queen's IRB, and they approved it. And then I went through the Western IRB per protocol, and they approved it very quickly because it was retrospective. I wasn't going to release any patient names or anything. We weren't testing a new chemo product. We weren't testing a new type of surgery. It was very safe, I guess, in the cancer world. But Queens themselves wanted a more thorough review of my IRB process. Understandably so. It's an undergraduate doing research, and they just want to make sure that all the bases are covered, that we were doing it appropriately. So that in all took about 6 months. It was a very long process, and I can say during that time I learned a lot about patience and how to advance a project without knowing if it's going to be approved and when it's going to be approved. Because it's important that when you're doing research, you remember your goals, your research questions, what you're trying to answer, and then looking at other people's research. So I did a lot of literature review during that time and really focused on what other people were doing and the results that they had. So what else was so that was kind of the downside of my research or my research experience, having to wait. But I mean, it's very realistic of what happens to other researchers. So now that we have that experience, what was some positive experiences I had? Well, I had 2 really positive experiences, or I guess you could say 3. The first one was I actually received funding from the Undergraduate Research Opportunities Program at the University of Hawaii at Manoa for $5,000. And this allowed me to travel to the Western Institute of Nursing Conference, arguably one of the best conferences in the Western Hemisphere. And this allowed me to present my research as a poster presentation. And there was a lot of PhD students and master's students there. I was maybe one of 2 undergraduate students, and the other undergraduate student was also my classmate. So, I mean, that was a very rewarding experience, knowing that everything I put into my research was finally paying off. And then my third experience with research that was the best probably was the relationship I created with my mentors. I don't think before I knew how valuable mentors could be in your profession. I've had mentors outside, and they've done a lot for me. But in your profession, it becomes different because you can ask them things about it that they understand and know, and they can kind of guide you and listen to you. And it makes you feel like you're not going through it alone. And if I had to do this alone, it would have been much, much more difficult. But I didn't. I had 2 amazing mentors and advisors. One of them was my Queen's advisor, actually at the hospital, and he did so much for me, helping me along with the research process, so the IRBs, the protocols, all those kinds of things. And then my honors advisor, who also helped with that, but she also helped me write my paper, worked with me on my project, worked with me on my PowerPoint, worked with me on my poster. Not only that, but she offered a lot of advice for future reference of what I wanted to do and how to accomplish my goals. So that was my experience doing research. It was probably one of the highlights of my nursing school. And if you're watching this, I recommend you do research if you're passionate about it and if you have a topic that you really want to find an answer to or to help people, because it's very rewarding. You're adding not only something to the body of science, but you're also helping advance the science of nursing, and that's very important as we grow and our responsibilities grow. So if you want to do research, I encourage you to do it. It's probably one of the most rewarding things you can do. All right. Bye.